All right, I'm just going to step away and get a cup of coffee.
Hi, everyone. We still have a little less than 10 minutes before we get started. However, I am going to put a link into the chat. So we're looking to gain some more insight on the patient populations that you serve. So if you could just take a couple minutes to complete this survey, that would be really helpful for helping Max and our Max for Moms program tailor our services to what you need. And that survey is totally anonymous and definitely optional. We will give it about 5 more minutes before we get started. Once again, please take the time just to introduce yourselves and your credentials into the chat. Also take a moment to complete the survey that I just put in the chat. This is a needs assessment for our Max for Moms program, but we would love some more insight on your patient population and your prescribing practices. The survey is super quick, totally anonymous, and optional. We are going to get started in about 3 minutes. I do see that someone raised their hand. As you may have noticed when you did log in, your cameras and microphones are disabled just to accommodate a larger audience size. So I do ask if you have questions, concerns, or tech issues, please put those into the chat. If for whatever reason you cannot access the chat, feel free to reach out to me via email and I can help you through those tech issues. We will get started shortly, but in the meantime, please introduce yourselves in the chat and take a couple minutes just to complete the survey that I threw in there as well. I know it isn't quite noon yet, but I do want to get started since we have a lot of housekeeping to go over. So thank you all for joining today's webinar. We are offering CMEs and CEUs for today's training. Please make sure that you can access the OASIS portal, which you use to register for today's training. If for whatever reason you don't have the link for that or you forget how to access it, those instructions will be included in a follow-up email that I will send out after today's training. And that follow-up email will include a copy of the slides as well as some additional Max resources. We actually have a brand new adolescent care one-pager available for you. So we are happy to share that. Dr. Fishman did contribute to it. So I'll ensure that you receive that via email as well. And that will be available on the OASIS portal too. So in that OASIS portal, that's where you'll fill out the evaluation. And once you fill out the evaluation, you will be able to download your certificate. We do have to enter your attendance into the OASIS portal manually, so it may not be there until the end of the day tomorrow. So just give us a little bit of time, but if you're not seeing it by early next week, definitely reach out to us. Today's webinar is being co-hosted by the Maryland Addiction Consultation Service and our sister program BHIP, which stands for Maryland Behavioral Health Integration in Pediatric Primary Care. Max and BHIP services are very similar, just with different demographic target populations. So I'll start by introducing BHIP and their services. So similar to Max, they do have a consultation warm line that you can call with questions specific to behavioral health of adolescent and pediatric patients, including questions like medication management, diagnostic issues, developmental delays, school learning issues, autism spectrum disorders, trauma, and early childhood mental health. Similar to our warm line, please call with de-identified information. It is a warm line, so it's Monday through Friday, 9 a.m. to 5 p.m., not an emergency hotline. They also offer referral and resource networking, training and education, including webinars similar to today's, and social work co-location. So we'll make sure that their information gets into the chat as well, but our model here at Max is based off of their model, but we adjusted it to help support providers in treating patients living with substance use disorders. So we help providers, including physicians, nurses, pharmacists, and other members of the healthcare team. Our services also include a consultation warm line. Just call us with substance use disorder related questions or pain management related questions. And that can be for any patient population, age. Once again, just make sure that you're calling us with de-identified information. We offer webinars similar to today, usually 12 p.m. to 1 p.m. to accommodate your busy schedules. Sneak it in during the lunch break. A lot of those webinars do offer free CMEs and CEUs. Many of our CMEs do count towards the now mandated 8 hours of addiction training required for anyone who is a DEA license holder who's looking to renew or apply for the first time. We have more information about MAID Act and how it impacts you on our website, so definitely check that out. We offer technical assistance, which is basically our way of helping you expand your office-based substance use services. That can be anything from finding an office space to helping you and your practice make sure you're all on the same page and using standardized screening tools and treatment processes so there aren't confusions or inconsistencies there. Similar to webinars, another medical education opportunity we offer are our echo clinics. Echoes are different from webinars because they're a little more interactive. You or another member of the medical community present a de-identified case. You pose questions about what you're struggling with treating that case, and then you hear feedback from peers in the medical community as well as a panel of our expert consultants. That's followed by a short didactic presentation. Those rotations happen on a monthly basis. It's a rolling enrollment, so if you miss 1 month, you can always show up the next one. You won't be penalized for that. And once again, really great way to earn free CMEs and CEUs while also improving your own practice and treating your patients to the best of your ability. And finally, similar to Max, another service that we offer is specific to maternal health providers, and that's our Max for Moms program. So all the services we offer for Max, we do have specialists on our team who can answer maternal health related questions for any pregnant and postpartum patients with substance use disorders. I'll make sure that all of that contact information is in the chat. Last housekeeping items, your cameras and microphones are disabled to ensure that we can accommodate a larger audience size. So please make sure that you're communicating with us via the chat. We will have a time for questions and answers at the end. And finally, I will introduce our presenter. Our presenter for today is Dr. Mark Fishman. And Dr. Fishman is an addiction psychiatrist. He's the medical director of the Maryland Treatment Centers and a member of the psychiatry faculty of the Johns Hopkins University School of Medicine. Dr. Fishman leads Maryland Treatment Centers, a regional behavioral health care provider, which includes Mountain Manor Treatment Centers in Baltimore and Emmitsburg, as well as several other inpatient and outpatient programs. In that role, he has been involved in development and implementation of innovative programming in addiction and co-occurring disorder treatment, and his clinical specialties include treatment of drug-involved and dual diagnosis youth, opioid addiction in adolescents and adults, and addiction with co-occurring psychiatric disorders. His research has focused on medication treatment for substance use disorders, as well as models of care and treatment outcomes in youth, in particular opioid addiction, and he has been a president of the Maryland Society of Addiction Medicine and is currently a member of its board. We are very fortunate to have Dr. Fishman as our presenter today. Please ensure that you're putting those questions into the chat so you can really take advantage of him as a resource, and I'll make sure that that one-pager he contributed to is once again sent out via email today. Dr. Fishman, without further ado, I will turn it over to you. It does not look like your slides are up, so let me know if you need any help getting those back up. But other than that, that looks great.
Thank you, Bridget. And I just want to second, maybe even third, what Bridget said about MAX, the Maryland Addiction Consult Service. Among all those other services, the idea that clinicians in the community can get real-time access for consultation and advice about real clinical cases. It's a great resource. You get access to real frontline experts. And if you call about youth, adolescents, or young adults, unfortunately you have to put up with me, but there's access to a lot of folks that really have a lot to contribute, and it's a really great resource and a national leader of its kind. So I'm going to be talking today about opioid addiction, opioid use disorder in youth, and by youth, or as they say in Brooklyn, youths, I'm talking about both adolescents and young adults, right? There's no bright line really of demarcation that's chronologically age-based. It's more a developmental continuum and having to do with the vulnerabilities of youth development and both maturity and immaturity, vulnerability and resilience. Here are my disclosures. I think the most important thing that you know is that I've been a consultant and had some research funding from some pharma companies that make medicines for opioid addiction. I don't think that biases me, but you guys will have to be the judge. And here's an outline of what we'll be talking about today. I'll start with a bit of the scope of the problem, but I won't spend a lot of time on that. You know how terrible it is. And focus largely on what we know and what we're learning and what we aspire to learn about treatment, including medications for opioid use disorder, including one of my favorite topics, family involvement and engagement, which I think is so critical across the lifespan, but certainly and especially for young people. And then I'll illustrate some particular examples of innovative, developmentally informed approaches, including something my group's been working on for several years, the Youth Opioid Recovery Support Intervention, but also some other things. And then we'll have some time for questions and discussion. I was very pleased to see in the chat so many youthologists here today. So again, you guys are here presumably because many of you are working with young people, and that's terrific. And those of you who are interested, who haven't been doing that, are interested in venturing a toe into that water. Good luck to all of you, and brave souls that you are, but I certainly advocate that it's important work and much needed. Here's a bit of an overview of what we'll be talking about. I like to think of opioid addiction not just as one isolated thing that begins when people get addicted to opioids, but as part of the full spectrum of substance use, substance involvement, and substance use disorder writ large across the spectrum of substances. Opioid addiction in particular is a subtype of SUD that is an advanced malignant form, but all SUD usually begins in youth, OUD as well. And we'll talk about that with a brief message about prevention in just a little bit. Adolescents and young adults as such are particularly vulnerable. Young adults have been disproportionately affected in the last several waves of the opioid epidemic, and adolescent involvement is certainly increasing. The evidence, both in research and in expert clinical consensus, for the primary use of MOUD, medications for opioid addiction, or as we sometimes have said in the past, MAT, medication-assisted treatment, or medications for addiction treatment, in youth as in across the lifespan are standard of care, but the dissemination and uptake of those medications as tools has been poor. Lots of problems with underdevelopment of treatment capacity, with misinformation, with prejudice against both youth and families and the medicines in particular. So broader uptake of MOUD, you'll hear me say again and again, is vital as a cornerstone of treatment, and that includes MOUD forward approaches, not to say that medicines are the only thing, not to say that we, of course, shouldn't be thinking about broad, multi-component, integrated and holistic treatments, but the medicines are the urgent need for starting and engaging and saving lives, and we'll certainly come back to that. Unfortunately, as good as these medicines are, youth don't do as well for the same reasons that they are vulnerable and develop these disorders. They have problems with adherence, problems with treatment retention, et cetera. And problems with treatment system limitations. So the idea is we need to do better there. And what I'll call for, and I'm sure you see the need as well, is improved strategies that address this gap for youth. We need improved treatment capacity, improved strategies for engagement, and developmentally informed, developmentally specific approaches that are particularly and especially good at targeting youth. And I'll show you some examples. And as I said, Youth Opioid Recovery Support is one such example. Here's a bit on the scope of the problem. You've seen this kind of curve again and again in terms of looking at the last decade or couple of decades of the opioid epidemic. This narrows this problem down to adolescents. And although the numbers of adolescent overdose deaths are not as high in absolute numbers as adults later in the lifespan, the shape of this curve is familiar to you, right? The explosive increase in overdose deaths attributable to synthetic opioids, mostly fentanyl and its analogs, taking off since the mid-2010s, right? And if you look in the right-hand chart, you can see that although, as I said, the absolute numbers of adolescents who are having fatal overdoses are relatively small, the increases in those numbers is alarming. And in 2019 through 21, some of the years for which we have the most recent data, the increase in adolescent overdose deaths were proportionately the highest across the lifespan. Again, from small numbers, but looking at these steep increases, very concerning. You guys probably know this, but just a reminder of what the problem is. Fentanyl is so potent, 50 to 100 times more potent than heroin. It's a funny thing that we say these days, nostalgia for the good old days of heroin. What a ridiculous thing to say, right? But it is true. It is so easy to miscalculate with doses of fentanyl that both inexperienced, but even the most experienced users can easily make a mistake and die with any single dose. And much of the problem, and this is especially a problem for youth, is that the drug supply with illicit fentanyl on the streets, mostly manufactured in bucket labs in Mexico with chemical precursors imported from China. But a lot of that supply is sold as counterfeit pressed pills that are manufactured to look like Percocet or other opioid pain medicines, or like Adderall or like Xanax. And here are some pictures, for example, these blue M30s, which are pretty good counterfeits of Percocet, and many young people who may crush them to sniff them or smoke them, or later on as they progress to inject them, may call them Percocet and may not know that they're fentanyl, or may half know and not want to admit it, but they will call it Percocet, or in Spanish, Perco. And the idea that some know, some don't know, there's other contaminants of the drug supply, the cocaine and methamphetamine supply to a lesser extent, even maybe the cannabis supply. And so it's both youth that are seeking opioids, but not necessarily seeking fentanyl, that can have this problem, but it's youth who are seeking other drugs, not opioids, who can have this problem. And of course, all of that makes it so dangerous. I just want to make a plug for prevention. We're going to be spending our time talking about treatment, and particularly specialty treatment for OUD. But as with any epidemic, you can't just treat your way out of the crisis. You got to prevent the pipeline of future cases. And so it's important to say a word about prevention. I like to think about addiction as a developmental disorder of pediatric onset. Remember, 95% of people later in the lifespan as adults who have substance use disorder develop their problem before the age of 18. So we need to focus on prevention in the teen years. The vast majority of youth who initiate opioids started their career, if you will, with addiction, not with opioids, but with what I call pre-opioid substances, having lost control over the typical teen substances, nicotine, cannabis, and alcohol. And so we want to think, as I said before, of opioid addiction, not just as its own isolated illness, but an advanced stage in a progression of the continuum of illness that is SUD. And we want to intervene early before they get to opioids. So intervening for non-opioid SUD prior to opioid initiation is in itself OUD prevention, is in itself OUD overdose prevention. So that's another rant for another day, but an important thing to emphasize. All right, let's jump to treatment, which we'll spend most of our remaining time talking about. And I want, as I said, to focus on these medications. So we've got three, as you guys well know, three FDA-approved medicines for the effective treatment of opioid use disorder: methadone, buprenorphine, and naltrexone. And we know that they are the standard of care across the lifespan for adults. And my message today is that the evidence and clinical expert consensus is very clear that the same thing applies to young adults and adolescents. They are safe and effective. They should be first line. We've got the most information about buprenorphine. We've got increasingly promising information about extended release naltrexone. We don't have as much research for adolescents as we do for adults, but we've got enough to be clear about this message. There's no signal for safety problems based on age, right? That's important. We don't want to be poisoning young people with medicines that are more harmful than the illness we're treating. And although, of course, all medicines can have side effects, these are no exceptions, there's no additional risk or side effect profile discovered so far that is conferred by chronological age. So we don't have to worry that these are problematic for adolescents and young adults. Now, we do have a problem with FDA labeling, and that puts some people off, but you probably know that most of what we do in all fields of medicine is off-label, because the initial $200 million that pharma companies spend on getting a FDA labeling for a very narrow indication population, then once a medicine is released, we get more information, we get more research, but nobody's going to be out there spending $200 million a pop to increase the labeling each time we discover a new population or a new use. I think it would be helpful for the labeling to increase, because I know some people, in my mind, are overcautious and over-restrictive about that. But I want to be clear about the message that we are allowed, because these are FDA-approved medicines, to use them for any age. They are safe. They are effective. And in saying that, I want to, and I'll show you some data about this, although they're effective for adolescents and young adults, unfortunately, for the same developmental vulnerability reasons, they are perhaps less effective than they are in older adults. And we have to work to improve effectiveness, to improve engagement, to improve retention and adherence. They're still very effective, and they ought to be first line. They should not be thought of as fail first. That is, let's give young people an opportunity to benefit from treatment without medications first. And if that doesn't work, okay, then maybe grudgingly we'll give them medications. Absolutely not. There is no evidence that that's an effective approach. Medicines are the most effective treatment. We should have a medicine-forward approach, later bringing in, or additionally, or simultaneously bringing in other treatment components, therapy, counseling, a variety of other things, but lead with the medicines. And when you talk about fail first, what does it mean to fail? Are we going to wait for an overdose or even a fatal overdose to say that a first line, some other treatment has failed, and then consider medicines? Makes no sense. So should be the standard of care, increasingly becoming the standard of care, but unfortunately, plenty of barriers to uptake. I want people to know that key professional societies have also endorsed the message that I'm telling you today. Just examples from the American Society of Addiction Medicine. Oh, wait, it says addition medicine. It sounds like an arithmetic society. That's a typo. It should be addiction medicine. And the American Academy of Pediatrics. And we can talk in the Q&A more about particular dosing issues or about approaches to initiation and the like. But bottom line, medications, standard of care, first line, no presupposed limitations on duration. We can also talk about duration. One of the things that is often a problem for families, for parents, for kids is, what do you mean, Dr. Fishman, I have to be on these medicines for the rest of my life? No, I never said that. But let's at least get you on them for a period of time that is stabilizing. And by that, I don't mean days or weeks or months, I probably mean years. I tend to say at least give me a year. Not that we have data about that, but the idea that whatever you've lost in addiction, we want to solidly stabilize you or help you get stabilized to the point that it's reasonable to think about coming off medicines. And unfortunately, the evidence that we have from older adults is that most people who stop medicines relapse, and there's probably no reason to suspect that that's different for youth. Here's just one example of the evidence base for the effectiveness of medications for OUD with adolescents. This is a large Medicaid multi-state claims database. This is work by Scott Hadland up at Harvard, and it's comparing youth with OUD who either received medication or received treatment without medication, and it's comparing 1-year retention rates in a survival curve, and you can see that those that receive medication are retained at a very substantially greater rate. So that's the good news. The bad news, unfortunately, is that uptake is very poor, as I've said before. So in this particular study, only 26% of all of these thousands of patients examined received any medicine, and for those under 18, it was only 5%. So we need to do better, clearly. So maybe that's all we need to do, right? Put more buprenorphine in the water. If only it were that easy. You probably know that retention rates across the lifespan are alarmingly low. In the best research, we probably have retention rates for adults at 6 months of 50%. In real live Medicaid, real world care, that number probably goes down to under 30%. And so we need to think about engagement, retention, adherence strategies that can improve our outcomes. It isn't just going to be writing more prescriptions. I want to give you a clinical vignette that is a composite case that just illustrates some of what we're up against. So let's take some 18-year-old young man, but it could be a young woman, and it could be a 16-year-old adolescent. It could be a 25-year-old young adult, same concepts. This is a person who's been smoking cannabis since age 13. That's very typical of the progression, as I said, from pre-opioid substances to opioid substances. They begin sniffing or smoking or both so-called Percocet at age 17, but it's not Percocet. There's really, in Maryland certainly, and in much of the country, there's no Percocet in the illicit market. It's all counterfeit pressed pills, which is fentanyl. This person progressed to daily use with withdrawal within 8 months of first initiation and injection 6 months later. And that's very typical of the compressed trajectory or course of progression of opioids from first initiation to daily use with full physiological dependence and withdrawal within less than a year, and injecting, within a year. And contrast that, if you will, say with alcohol, very different pharmacological approaches. That's why we talk about it as an advanced malignant subtype of SUD. You wouldn't expect progression from first sip of beer to half a handle a day of vodka within a year, right? That typically takes 30 years. So again, different in terms of the acceleration of course. This is a person who's had some treatment, been in residential treatment a couple of times, left prematurely against medical advice once, another time completed to the end of recommended residential treatment, but in both cases, never showed up for the intended, recommended, referred continuing care or continuation medicine if they even started medicine. This person also initiated a course of buprenorphine treatment as an outpatient once and got a monthly supply prescription with 4 refills, have a nice life. That didn't work out so well, took it erratically, sold half of it, continued to use fentanyl during that time, and had no persistent abstinence. So not exactly an advertisement in this case for the effectiveness of high quality buprenorphine treatment, right? Anyway, he's back again. He's relapsed. He comes to me. He comes to you. Says, listen, I've been in trouble. I'm in 7 kinds of problems, I've been thrown out by my family. I've broken up with my girlfriend. I'm in trouble with the law. I've been fired from my job. I've been kicked out of school. You name it, all of those things that you're used to. Dr. Fishman, I know I may not have done it right in the past, but I've done a lot of soul searching, and I really want to quit this time. And I'm in a whole heap of trouble, and I'm sick, and I'll do anything you say. I'll stand upside down, naked in the rain, if that's what it takes. But you know, I'm kind of in a hurry. And I was wondering if we could be finished by Friday, because there's a really good party I want to go to on Saturday, and I'm hoping I can get back with my girlfriend who's kind of mad at me, et cetera, et cetera. Oh, and by the way, did I tell you I have a terrible anxiety problem, and I've tried everything, but nothing works except, you know the drill, Xanax. And no, you can't talk to my Xanax doctor. Oh, and no, I don't want you to talk to my mom, because what does she know about all this? But other than that, I'm an open book, and let's get on with it. Now, I don't mean to trivialize this young man's suffering or to make fun of him. This is obviously a very dangerous situation, and he's at great risk, including of fatal overdose. But I just want to pose that as a puzzle, that it's difficult outside of a brief crisis to engage patients generally, but especially to sustain engagement with young people. And we need to think about developmentally specific ways of keeping this person in care, meeting them where they are, and trying to do better. Part of what's different about young people are, as I said, all of the developmental vulnerabilities. They are invincible. They are largely immature. If you think that patients across the lifespan have trouble with waxing, waning motivation, that's even 100 times more salient for young people who may have motivation in a crisis for a nanosecond, but it's up and down and up and down, and it changes rapidly. And the idea that treatment is appealing to them, we think, of course they would want treatment. Don't they want to save their lives? Aren't they looking for a better life? Well, treatment's not very youth-friendly. In fact, most kids tell me it's pretty lame. And the idea of how to engage them when they got so many things they'd rather be doing, I think, is front and center for us. They tend to have a subjective perception of less salience of consequences compared to their older adult counterparts. That is, they don't have as many life role responsibilities, fewer mortgages, fewer alimony payments, fewer job responsibilities. So things haven't caught up with them in terms of road miles and consequences. And besides, they're invincible anyway. They don't want to think of themselves as a sick person. That's especially problematic in terms of asking them to take a medicine in a maintenance way for a chronic remitting relapsing illness. What do you mean I have a chronic remitting illness? That is totally a youth unfriendly concept, not just for OUD, but if you've ever treated a young person with diabetes or epilepsy or arthritis, it's very, very difficult to engage them. And then, although everybody thinks of treatment as burdensome, young people especially, there's also a very normative pushback against their subjective sense of parental dependence and the restrictive reliance on adults. We'll come back to this when we think about family engagement as a treatment strategy. But young people very appropriately have one foot in childhood, but another foot in emerging adulthood and progressive independence and autonomy. And they want to think of themselves as all grown up. You can't tell me what to do. My mom can't tell me what to do. I've got this. And so what are you bothering me for? And then there's lots of prominence of psychiatric comorbidity, which we don't have really much time to talk about today, but it is also very important to emphasize. I just want to show you a little bit of data that emphasizes the point of the variable effectiveness of MOUD in youth compared to older adults. Glass half full, glass half empty. This is a secondary analysis of the XBOT study. You may know that was a randomized controlled trial comparing sublingual buprenorphine to extended release naltrexone. across multiple sites. There were some 450 participants. It turned out that about 100 of them were young adults between 18 and 25. And so we reanalyzed the data, not medicine versus medicine, but age versus age. So the outcomes over 6 months, non-relapse survival curves shown here in those over 26 versus under 26. And what you're looking at is who is residually non-relapsed at the end of 6 months. And you can see this big gap, right? So 49% of the adults have not relapsed by 6 months, but 34% of the young adults have not relapsed. So as I said, half full, half empty. 34% is certainly better than we would have had without medicines. So again, the medicines are effective, but there's this gap in terms of what we need to do better to sustain engagement and adherence in young adults. And although there were no adolescents in this study, that goes even tenfold for adolescents who are even more vulnerable and less mature than young adults. Another example of that same point, this is a study we did in adolescents and young adults presenting for acute crisis-driven treatment in inpatient, some 300 of them. Our standard of care was to try to get them all on medicine. So the first point is that although many of them did accept medicine, a quarter of them extended-release naltrexone, a third of them buprenorphine, over a third of them said, no, thank you, I don't want your stinking meds, despite our saying this is what you need to them and their families. So that's the first problem. Second problem is even those that did accept initiation of meds in the crisis-driven setting of an acute inpatient treatment, when we looked over 6 months to see what follow-up medication engagement and adherence was like over the ensuing 6 months, was really quite alarmingly low. Only 1.3 average doses of extended release naltrexone. Remember, we'd expect 6 doses in a monthly medicine, and only 57 days of buprenorphine coverage out of 180. So really very little sustained medication engagement and adherence in usual care. And the medicines, as you might imagine, only work if you take them. So what are we going to do about that? So I want to talk for a little bit about the tool of family engagement. And as our thinking has evolved over the years in what are the developmentally specific missing ingredients in the data I've shown you about this gap in engagement and adherence. What do we need to do different that takes into account developmental vulnerability? And I would argue that there are many things, and probably things I haven't thought of, but a lot of our work has been trying to think about how we bottle family engagement and how we use the natural connection and resources of families to improve outcomes. Now, there's lots of reasons why our field has done what I think is a relatively poor job historically for including families. One is the normative pushback against family over restrictiveness that I told you about, which adolescents and young adults, normally feel. But also it comes from us. We talk about addiction as a family disease, but I think that's largely been lip service in usual practice. Clinicians say, I'm not a family therapist. I'm not trained. I'm not comfortable. It's hard enough working with the patient in front of me. Now you're telling me I got to go chase other stakeholders and mom and dad, and they're fighting with each other. And what am I going to do? We tend to focus on internal transformation, which is important, but perhaps not the way that people, especially young people, initially change behavior with external leverage and extrinsic motivation rather than internal motivation. We talk a lot about enabling, and even though that may be a valuable concept, when we talk about it to families, what do they hear? Whether we intend it or not, they hear it's your fault. And we tell them to let their kids fail and let them hit rock bottom and stop rescuing them. And that's so unnatural, as opposed to what I would advocate as an approach of constructive engagement, and one that emphasizes the connection and leverage and persuasion of love and caring. And lastly, I think we have an important concern with confidentiality, which is, of course, is at the center of the treatment we do. But I think we're over rigid about it, and we don't do a good enough job trying to make sure that everybody's together and communicating, and that we think about it as our standard that we will include loved ones as appropriate, with consent, with permission, but it's about getting to yes, and you can almost always get to yes, rather than we can neither affirm nor deny that a person of that name is receiving treatment at this center. Please call our lawyers between the hours of 8:30 and 8:37. I'm exaggerating, but you get the point, and families don't feel very welcome. Now, when families first come to us, if we talk to them at all, one of the things you'll find is they are so embattled and crisis-driven. They're up to their ears in alligators, and they don't know what to do. They feel like they've tried everything, nothing works, and they don't know which way to turn. And they tend to have these polar extremes between, I'm not taking it anymore, I'm going to kill them, I'm going to throw them out of the house, I'm going to disown them, I'm done, versus, I don't want to know about it, don't ask, don't tell, there's nothing I can do, maybe not in my house, but that's the most I can ask for. And neither of those are really very effective engagement strategies. What we hope for is to be able to coach parents to take a middle ground that is consistent, that is persistent, and that is engaged and effective. We want to do that because families have juice. They have core competence that comes out of their deep connection and special powers of love and persuasion. People may be interested or not in what I have to say, but they're much more interested in what the people who've known them all their lives have to say, and who have engagement, who have persuasion. And we want to mobilize families to use their juice, and they usually have more juice than they know, but we've got to coach them. And some people say, or would argue, or would criticize, or would question, well, wait, which is it going to be? Is it going to be empowering families and infantilizing young people, or is it going to be empowering young people and their emerging autonomy and self-efficacy? And I think that's a false dichotomy. I think empowering families and empowering the young patients are compatible and in fact synergize each other. So how do you do that? Well, you certainly have to coach the families, because, as I say, they don't know what they're doing out of the gate, and they've tried lots of stuff, and they're miserable, and they're worried the kid's going to die, and they've tried a lot of stuff. They say everything, maybe not everything. They tried a lot, and they're scared, and they're not being effective anymore. So you got to do all this kind of stuff. Teach them about picking your battles, teaching them about using their resources and knowing your leverage, and figuring out that rewards work better than punishments. You can get more flies with honey than with vinegar, that you got to give to get. Why should I have to give them something to do the right thing? Well, because what you're doing now, how's that working for you? Maybe try something different. And you have more juice than you realize. Well, I'm not made of money. I can't pay them to be sober, or pay them for every negative drug test, or buy them a car just because they went to treatment. Or no. Every family has got some resources. Every family has got something of transactional commerce that they've got, even if it's just attention and being nice and spending time. But is it nice meals? Is it family outings? Is it, God forbid, cigarette money? Whatever it is, and I'm not endorsing that, but whatever it is, how about tying it to treatment goals and treatment performance, and thinking about shaping behavior through the known principles of operant conditioning And so that's part of what we teach. We've also got to teach that it's the long game, not the short game. Every little lapse is not a catastrophe. Keep your eye on the prize. This is a marathon, not a sprint. Let's focus on what's most important. I can't tell you how many times I've had the conversation with families about when they say, can't you get him to clean his room? Well, I don't know. You get to pick what the main treatment goal is, but I wonder whether that's more important or whether smoking fentanyl is going to be more important this week. Maybe we'll get to cleaning the room next week, but think about what's most important. Got to de-escalate the families, got to get them to be focused. An example of an intervention, how am I doing for time? An example of an intervention that we've developed and refined over the last almost decade now that incorporates some of these principles is what we call the Youth Opioid Recovery Support Intervention, or YORS. And it has these elements: family involvement as a cornerstone. So everybody who comes to the intervention, we ask them to pick a treatment significant other or treatment or TSO, often a parent, but whoever they choose. Could be a boyfriend, girlfriend, could be an aunt, an uncle, a grandma, could be a sponsor, a mentor. But pick a partner, an adult partner, who can be part of the team to collaborate with your treatment goals, especially around medication adherence as the primary goal. Assertive outreach, not waiting for you to come to us. We're going to be out there as the used car salesman of recovery, if you will. Low barrier access to MOUD, whether that's delivering medication to your home or whether it's telehealth prescription or whether it's getting you an Uber or a Lyft to come to the clinic to get an injectable extended release dose of extended release naltrexone or extended release buprenorphine, and then contingency management incentives for receipt of the medication. Now, this is a lot of stuff and it's not cheap, and we're able to do it because we have fancy pants research grants from NIDA to be able to do it. So I'm not saying that this is trivially replicatable in every treatment setting, in every clinic across the country, but I think some of the principles that are embodied here are translatable, especially the idea of family involvement and low barrier access to medications. The idea of assertive treatment is not new. We didn't invent it. It's used, you may know about assertive community treatment for chronic relapsing serious and persistent mental illness, ACT for schizophrenia, but also observed medication administration for tuberculosis or HIV. So we ride on the shoulders of giants and kind of thinking about how to incorporate those elements. The family engagement centers around this partnership between the youth patient, the therapist, and the family, negotiating and developing a treatment plan, negotiating the communication rules of the road, who can know what, how do you want to be communicated in. Most importantly, what's the backup plan if things go bad? Well, we don't need a backup plan. I'm serious this time, Dr. Fishman. I'm in, I'm for real, I'm good. Well, all right, but humor me, and just in case, while everybody's feeling motivated, let's get a backup plan and a backup to the backup plan. Young person, what would you like your family to do if, God forbid, things go sour? Mom, in your family, how would you handle it if things go sour? And we go over the scenarios. You miss a session, you miss a dose of medicine, you have a slip, you have a positive urine, you start using again. What are we going to do? Let's write it all down and get it sealed now before there's a relapse, before there's secrecy, before there's hiding. Not that it's a legal document or binding or anything, but it's a ritual in terms of getting people to think ahead and be able to plan. Here's an example of a particular case that went well and emphasizes the idea of the authority and leverage of an involved treatment significant other. This was a young adult. Our research grants to date have been in young adults rather than adolescents, but it was a young adult who'd had lots of treatment, who'd been injecting heroin, who'd had several doses, initial doses during inpatient care of extended release naltrexone. The same could apply to extended release buprenorphine, but never came back for a second dose, never continued in referred outpatient care, kept relapsing and coming back on the revolving door of detox and rehab. This time he enrolled in the yours intervention. Grandmother, who was the adult caretaker that he lived with, was the designated treatment significant other. And so a month later, his next dose of extended release buprenorphine or extended release naltrexone is due. Knock, knock. In comes the nurse and the therapist. We've got your dose. And he says, you know what? I've changed my mind. No, thank you. I don't want your stinking medicines, as he had done before. And I can't read his mind. I don't know if it's because he's already relapsed. I don't know if it's because he's contemplating using tomorrow. I don't know if it's he wants to keep his options open to use, or maybe he's committed to abstinence and thinks he's invincible and doesn't need medication. But whatever, he says no. But grandma, who's got more juice than I do, than the nurse does, than the therapist does, she says, what are you talking about? Of course you're getting the dose. And she's got the juice. And he gets the dose. This particular person gets all 6 doses in the 6-month intervention, and he's kind of our poster child. Now, it doesn't go this well for everybody, but that's what we aspire to. Some other examples. Here's the case. You come to the house to give an injection, and the mom's following the team around. We're looking for a private place in the house to give the injection. Ma'am, you can't be in here. This is a private healthcare intervention. Mom, get out. That's embarrassing. And the mom says, no, of course I'm going to watch. I'm going to watch his medicine go in you, and I'm not leaving till I see it go in you. Now, I'm not necessarily endorsing this mother's intrusiveness, and maybe she's being a little overdramatic and shrill, but I use it as an example of creating a role for the family treatment significant other as being a champion for sustaining the treatment. And think about it, if you will. In every other subspecialty of medical care, it is our intuitive instinct to help a loved one who's in trouble and having difficulty navigating the healthcare utilization system. Granny can't take her pills. We help monitor them. Your loved one, God forbid, gets a diagnosis of cancer and can't process all the information coming at them at the doctor's office. We go to the visit and we take notes and we ask questions and we make sure that they get to the next visit. That's just what people do. But somehow in substance use disorder, it's secretive, it's shameful, it's in the shadows, and we haven't defined explicit roles for families. So this is, I think, a pathway, if you will, to empower families to be able to have a role. Now, they've got to learn to do it in a non-punitive way. They've got to learn to do it in a way that's digestible and supportive, but in a way that helps someone who's in crisis and not necessarily on their best game mediating healthcare utilization to do better. We've got some research results. I'm running out of time, so I won't spend a lot of time on that, but we've done this study when we had extended release naltrexone only. We repeated it when there was choice between extended release naltrexone and extended release buprenorphine, and people get many more doses in the yours condition than they do in the treatment as usual condition. Here are the non-relapse survival curves. People have much lesser rates of relapse in the yours condition than they do in the treatment as usual condition. And there's 2 things to say here. One, that it shows the efficacy of the intervention. It also shows how ineffective current treatment as usual is. But there's certainly still room for improvement in the yours intervention, because you can see that the results I'm bragging about are still over 50% relapse at 6 months, but that compares to 95% relapse at 6 months in treatment as usual. We've done some refinements of the intervention to include a peer-to-peer treatment significant other Zoom-based support group. We've begun doing deliveries with the van. That was something that we came up with as an infection control change during COVID. We've obviously incorporated lots of the advantages of low barrier telehealth. I want to spend a couple of minutes on some other innovative practices. One is trying to get youth serving primary care to be involved in MOUD. The work of Sharon Levy up at Boston Children's Hospital in the Massachusetts, Boston area, creating a specialty hub, delivering consultation and support to spoke family practice and pediatric practices. The idea that many young people may not want to go to specialty centers that say addiction on the front door, but if you could put this service into pediatric or family practice centers where they're already getting care, contraception, acne, whatever, that may be more digestible. Another thing that we're starting to get some experience with is using extended release buprenorphine for adolescents. So most of the yours work we've done to date has been with young adults, 18 to 26, but just recently we've begun pilot work with 14 to 18-year-olds, including using extended release buprenorphine, both the Sublocade brand and now more recently the Brixadi brand. Obviously, the idea is that extended release formulations of medication can help address adherence problems where you don't have to make a daily decision about taking the medicine or not. You're all in for a month. Maryland Medicaid fought us on this for a while, but we're getting more and more successful, but still on a case-by-case basis in getting approval. We don't have vast experience. We still need more research. We've submitted some grants to try to do some formal efficacy study of extended release buprenorphine in adolescents, so stay tuned for that. The idea of recovery housing that might be youth specific with MOUD forward approaches. The state of Maryland has funded us to stand up recovery houses both in Baltimore City and in Carroll County. And so the idea of a youth specific recovery support environment with concurrent outpatient care for young adults with appropriate supervision, but also with appropriate appreciation that young adults will get up to shenanigans and you don't need to boot them out because they break curfew and invite their girlfriend, boyfriend over. We've thought about going upstream. So all of the work I've told you about is for youth who present to treatment. But what about all the youth out there who are using, who aren't yet ready for treatment? And so the idea, based on the CRAFT approach, which many of you may know about, of using family engagement for loved ones, sometimes parents of out of treatment youth, and coaching a concerned significant other to try to help, if you will, lead the horse to water and get them to MOUD treatment. So we are got some grant funding and are recruiting to learn about that. So here's, you guys got the slides. Here's the contact information, but not just for youth, but across the lifespan for people who might have a loved one who have opioid use and are having difficulty getting them into treatment, using these family engagement techniques to try to coach them to get into treatment. And lastly, I want to tell you about this new resource with some startup support from the State Behavioral Health Administration and Montgomery County. We've just reopened a dedicated adolescent unit at our Mountain Manor, Baltimore location. So that's very exciting. This happened just 2 weeks ago. We're taking male adolescents 14 to 20, and then after some renovation in a few months, we'll start taking females. But the idea that we've been typically admitting adolescents to our adult units, which is less than optimal, for all sorts of reasons, including effectiveness and concerns about safety. But now we've got a dedicated, developmentally specific youth unit, and so excited about that. Here's some referral information. And so just want to conclude with the idea that we have these tools. They are all life-saving tools. We're working hard at figuring out developmentally specific enhancements to OUD treatment that will improve engagement, that will improve medication adherence, that will improve retention for young adults and adolescents. But we got to do better because, as I said, uptake is problematic and there's a big capacity gap. So I'll stop. I think we have some time for questions. And let's see what's in the chat.
Thank you so much, Dr. Fishman. We have had a handful of questions come in, so I'll get right into them. You may have addressed this in your talk, but someone asked, I know it depends patient to patient, but what is the average length of course for OUD treatment? 6 months to a year?
So it's a great question. Nobody really knows the answer. The adult data tells us that the majority of patients who stop MOUD do relapse. Now, that's not everybody, and there are many people who, after stabilization, are able to discontinue MOUD without relapse. It's just that we aren't very good at predicting who that is prospectively. We've got only Monday morning quarterbacking in the rearview mirror. But that's being studied, and you can make some presumptions about stability. It is certainly not while somebody's still using. It's certainly while somebody's still smoking cocaine. It's certainly not while somebody is still homeless, while somebody is still depressed, while somebody is still unemployed. So get back what you've lost in addiction, however long that takes, and then let's talk. I typically think of that as at least a year. We certainly need more research to be able to verify that. That's a hard sell. And most people, both older adults and young adults and adolescents, tend to drop out before that time. And so that becomes a problem. To tell somebody that they need to be on it forever, obviously, is a big engagement barrier. Nobody wants to hear that, so I never say that. It is true that some people do need to be on these medicines chronically, indefinitely, and forever, but at least a year. And we're waiting on the evidence to demonstrate that.
Great, thank you so much. The next question is, what is an effective way to convince a client to have a consent form for a loved one?
I think explaining it, telling them the reason, telling them that it's routine, making it routine. I'm not singling out you. It's not that I don't trust you and I'm going to want your parents to be looking over your shoulder and treating you like a baby. It's not that I want to rat on you. It's what we do. This is the standard of care. Your family loves you, cares for you. Yeah, they're a pain in your you-know-what. Yeah, they've got problems. Yeah, they need to refine the way they yell at you and all of that kind of stuff, but they can help you. Let me run interference. Let me try to help. You can always change your mind, but I'm working on getting to yes. I don't necessarily have to get yes day one, but I can almost always get there. And although patients will later say, you know, Dr. Fishman, I really was reluctant to let you talk to my family. I'm so glad you did. It's really helped me. And in the end, honesty, openness, and support, if you can get there, is better than isolation almost every time. So it's about convincing people, which sounds hard, but actually isn't as hard as it sounds.
Great, thank you. Another question we have is, what are the side effects of, what are the side effects of long-term MTC? For example,
I think MOUD is what you mean. Yeah, long-term MOUD. So people can have sedation. Most people don't, but some people do. People can have constipation. People can have GI side effects. People can have urinary retention. People can have sexual side effects. Buprenorphine under the tongue when exposed to the teeth and gums has been associated with increased rates of dental problems, small amount, but nevertheless significant. Methadone people can overdose on, buprenorphine and naltrexone not so much. All of the agonists, buprenorphine and methadone, if you stop them suddenly, you will have withdrawal. That's an unpleasant side effect. Not so with naltrexone, but again, there is no perfect medicine without side effects, even Tylenol. And so everybody's got to make an informed decision about the balance of benefit versus risk and work collaboratively with a healthcare professional who can negotiate that, collaborate. And if A doesn't work, we got B. And if B doesn't work, we got C. And if C doesn't work, we go back to A and try different doses and different circumstances, and we never give up. Now, it's unfortunate that most healthcare settings can't give you in a one-stop shop all three MOUDs easily. So we got to do better with that. As you may know, methadone especially can only be delivered at highly regulated, specialized opioid treatment programs, OTPs, which tend to be isolated from other healthcare and from other sources of MOUD. We'll see what the future of regulation does about incorporating methadone into more standard addiction practice. But at the moment, it tends to get isolated. That's a problem.
Great, thank you. Another question I'm seeing, and this is a little more opinion-based. Why do you think there is such a lack of youth treatment facilities in rural areas? Should facilities like health departments be mandated to provide care for adolescents?
Well, it's certainly needed. Part of the issue is a resource allocation issue. There are far more older adults in absolute numbers. So if you just count hamburgers served, you're going to need more service delivery units for people over the age of 18 than less than 18. On the other hand, if you take a public health approach for prevention and early intervention, I think you ought to put a disproportionate amount of resources into youth, because early intervention in any chronic remitting relapsing illness will bend the curve and change the trajectory more than waiting 3 decades for it to become advanced, malignant, and crystallized. I don't know about mandating. Every public health department, every health department's got to do what it's going to do. I would certainly advocate that every health department ought to have youth services. And I think you don't necessarily need whole separate buildings. You can certainly have clinicians who can work across the lifespan. And you can train mental health clinicians who are generalists to also do addiction. So it doesn't have to be a whole separate building, a whole separate program, especially in rural areas where there's low densities. By the way, lack of youth services in rural areas is not the only problem. It's lack of any services in many rural areas. And so thinking about how to disseminate practices where people don't necessarily need close geographic physical access, like the use of telehealth, has been a huge advance. You can't do injectables by telehealth exclusively until we invent the drone delivery. We're working on that. That's the next grant. But in the meantime, prescription of buprenorphine with telehealth support has become a national model, with many very high quality providers doing it both in urban and in rural areas. And there's no reason why that couldn't also apply to youth. The big national players have shied away from youth so far because of the FDA labeling issues, because of risk issues, I'm sure. But I'm hoping that they will go in that direction because it's much needed.
Thank you so much, Dr. Fishman. The last question I'm seeing is specific to Mountain Manor, so let me know if you need to follow up with this participant directly. But they ask, are there bilingual clinicians out at Mountain Manor or access to language lines?
Yeah, we do have that. That's become increasingly needed, as you might know, since you asked the question. We've seen an uptick in Spanish-speaking kids and especially Spanish-speaking families. And so to be able to do the family engagement work, we've needed to move in that direction, and we need to do even better. So just a plug in terms of recruitment. Anybody who is a bilingual clinician and looking to do this kind of work, please ping me. But yes, the answer is yes, we do.
Awesome. Thank you so much, Dr. Fishman. I'll make sure that if any other questions come in, they will get to you. And if any other Mountain Manor specific questions come in, they'll get to you as well. And I'll make sure that your slides are sent out.
Yes.
Thank you all for being online today. The recording of today's webinar will be available on our website within 1 business week. Just look out for emails with the slides, follow-up information, and that evaluation information as well. Thank you all for being online, and thank you again, Dr. Fishman, for presenting. This was great engagement today.
Yeah, and just one last thing about Max. If you guys have questions, either about general adolescent treatment issues or about individual patients, call Max. Most of the time, if it's a youth question, you'll get to me. Reach out to me separately, either way. But it's a great resource, and I know you guys are out there doing this great work every day, which I greatly appreciate. And if you want input, please reach out to Max.
Awesome. Thank you so much. Dr. Fishman, I'm just going to save the chat and everything, so feel free to log off.
Okay, thanks so much.
Thank you.